Well, it's a privilege to speak to you this morning. I was asked to give a talk on brachial and lumbar plexuses, and I think after teaching neurosurgery residents and students for over 20 years, the thing that the residents struggle with, especially closer to the boards, are peripheral nerves. It's something that you don't do every day. Most institutions don't do enough cases to keep it fresh on your mind. And even our peripheral nerve surgeons, when they come to the OR, they usually have an atlas or a textbook or me there with them. So it's something that most people hone up on just before the boards. And then the thing that happens for me mostly are junior attendings about to take their oral boards, and they come in and we quiz them for a week or so and beef up their knowledge. So most of you as rising chief residents or chief residents, fellows, you're experts on the spine, you're experts on intracranial work. But I dare say if someone asks, are you an expert on the peripheral nervous system, most people would answer maybe not. So this will be a very straightforward primer for what I think is a niche, elementary / essential brachial plexus and lumbar plexus anatomy that is a good working knowledge to carry around with you. So everything starts here, and unfortunately clinicians use terminology that doesn't always go along with anatomical terms, but we talk about roots and ventral rami. So in essence, when clinicians refer to a root injury, they're often talking about this ventral ramus, right? So roots for the anatomist are these intradural fibers that are either dorsal sensory or ventral motor. So the genesis of all the plexi of the body come from these ventral rami. So brachial plexus, lumbar plexus, lumbosacral plexus, cervical plexus, etc. As we move on, everyone's seen the very cartoonish looking picture in the upper left here that demonstrates the parts of brachial plexus. If you memorize this before your boards, when you look at specimens in the lab, they look absolutely nothing like this, and confusion sets in there. So we have a very rudimentary understanding of the three-dimensional anatomy of the brachial plexus. The picture in the lower right gives a little better impression of what this anatomy looks like in the patient or the cadaver. And you'll notice that these branches, these ventral rami-derived branches of the brachial plexus huddle around the axillary artery. And in fact, it's that axillary artery that is the reason we say something's medial to it. So it's a medial cord, it's lateral to it, it's lateral cord, it's behind the axillary artery, it's a posterior cord. And we'll see that as we go through. Most undergraduate anatomy, when they teach the brachial plexus, they use that upper thing in the left, which anatomists don't like, and it throws people off. A better way of thinking of the brachial plexus is this interconnection of multiple fibers. And this is from an actual dissection, an old text where they removed all the external coverings of the brachial plexus, and it shows you how complicated it can be. And also, for example, in this picture, when you see a range for the ulnar nerve, and people always question, well, how does C7 get into the ulnar nerve? You can see exactly how C7 gets into the ulnar nerve from this picture, which is not that cartoon that I showed you in the beginning. So brachial plexus, a good way to determine the different areas is either say it's very simply supraclavicular or infraclavicular brachial plexus. And then we'll come to a point where we're in the axilla, which is where most of the brachial plexus is, and we see something like this. This is a parasagittal view and kind of shows you the landmarks of where this nervous system exists. Somewhere posterior to the pectoralis muscles, anterior to the scapula and its associated muscles, subscapularis, teres major, latissimus dorsi. You see in the upper portion of this figure the trapezius muscle. The floor of the axilla is basically open, so nothing that's forming a strict border there. So let's start off, look, we all know from back in medical school that brachial plexus is usually, and most folks, contributed to from C5 to T1 ventral rami is shown here. Those ventral rami, as they exit the cervical intervertebral foramina, are going to look like this in their composition. So they're sandwiched between the middle scalene muscle that we see here in the background, and then in the front, So here's middle scalene, and in the front and cut here is the anterior scalene. So between those two and the first rib forms this interscalene triangle where we see the majority of these ventral rami exiting. Sometimes these ventral rami will pierce those muscles, sometimes they'll go in front of them, but this is the general makeup. You also note that the brachial plexus and the ventral rami are posterior to the big artery that also lives in that interscalene triangle, the subclavian. So we see the subclavian here passing just behind the anterior scalene and about to cross the first rib and become the axillary artery. Also from this picture, you'll get a glimpse of some of the sympathetic communications between brachial plexus and the sympathetic trunk. So here's our stellate ganglia at the neck of the first rib, and we see some of the rami communicans. And remember, it's here at T1 that you get your first white ramus communicans, and hence your pre-ganglionic sympathetics enter here. That's why if you have a T1 involvement in a brachial plexus lesion, that you're likely to have a Horner syndrome just because of that connection. Again, a schematic, a cartoonish look, but this gives you an idea of the super and infraclavicular parts. And then also remember that below the clavicle, so if you remove the clavicle and look underneath it, you're looking directly on top of the divisions of the brachial plexus. So above this, we have rami and trunks. Just below, as in inferior to the rib, or excuse me, the clavicle, we have the divisions, and then distal to that clavicle, we see our distal branches, cords, etc. Again, a cartoonish view that shows you some of that anatomy. You can see the intimate relationship of the clavicle with the brachial plexus, and hence inferior displacement of the clavicle can injure those divisions and give you a plethora of different clinical outcomes. Here we see nicely the 5 through T1 ventral rami forming the brachial plexus. You have to remember, and especially with clinical exam, that a lot of folks walking around have a prefixed brachial plexus. So C4 also contributes to their plexus. And that may or may not include that they have only C8 in that range and that they've lost T1. A postfixed brachial plexus is much less common. You see that in up to about 4%, and that's more common with a cervical rib. You all remember that a cervical rib can place traction on the inferior aspect of the brachial plexus, and the most common clinical issue with that is someone may have an ulnar nerve issue that's due to this cervical rib. So let's start from top. We'll move down, quickly go through brachial plexus, and then go through some of the major parts of the lumbar plexus. Here we see, this is a beautiful picture. If I ever had to have a tattoo on my body, I think this is the one I would choose. It's very artistic and anatomical all at the same time. So small piece of clavicle is removed. We see the rami, right, of the brachial plexus, C5 down to T1, and you notice they're stacked on top of each other. So unlike the cartoons you see, when you look in the actual cadaver or patient, our upper trunk and C5s are kind of superiorly placed, and then T1, lower trunk, C8 are inferiorly placed. They run out through scalene medius, anterior scalene. A good landmark for anterior scalene is to see your phrenic nerve here. There's also an accessory phrenic available in most folks, and that's usually from C5. So you can trace those phrenic fibers or accessory phrenic fibers back up to your C5 if you're trying to find it operatively, if there's been trauma, etc. Long thoracic nerve, we all remember that this comes off of C5, 6, and 7 before you really start to intermingle those ventral rami, the brachial plexus. Innervates one muscle, serratus anterior, and as it's formed, it comes and usually pierces the middle scalene and runs inferiorly, posterior to the brachial plexus and the artery, and then descends down to innervate your serratus anterior muscle. Stab wounds to the neck, you can injure the long thoracic nerve here. We see its continuity here as it runs out distal along the serratus anterior muscle. And if you injure that nerve, you have a wing scapula because the protraction element of the serratus anterior is lost, and most commonly injured with mastectomies, where you venture out a little too laterally in the dissection. So long thoracic nerve C5, 6, and 7, ventral rami. Dorsal scapular nerve, a nerve most forget about or don't look at so much clinically. Dorsal scapular nerve, mostly from C5 ventral ramus, will also pierce the middle scalene and runs posteriorly because it's going to innervate usually levator scapulae, rhomboid minor, and rhomboid major. So this nerve, sometimes forgotten about, but often seen with deep dissections of the neck and innervating those three muscles, retractors of the scapulae, elevator of the scapula. You can see the prolongation here. So dorsal scapular, after it leaves the posterior triangle, is going to run deep on the vertebral border of the scapula, deep to levator scapula, rhomboid minor, major, and it innervates just those muscles. Suprascapular nerve, several times this has shown up on both written and oral boards. Just this morning, Charlie and I were talking about, and he was quizzed on this during his oral boards, and I've remembered other folks saying, so it's a nerve that's popular in the neurosurgical examination world. Suprascapular nerve from C5 may have some C6 fibers, leaves that upper trunk, runs underneath the suprascapular ligament, innervates supraspinatus and infraspinatus, and then distally, right before it gets to infraspinatus, it runs underneath this inferior transverse scapular ligament, which is a variation, but has to be remembered when you're thinking about decompression, etc. Suprascapular nerve, supraspinatus, remember, abducts the glenohumeral joint to about 15 degrees. Yes, sir?
I might just add that
Yep.
this is very commonly injured by a gangling cyst from the shoulder.
Yes. Yes.
And so that patients may present to us with C5 radiculopathy.
Great
and
point.
We need to carefully examine them. EMG picks this up, and
Yeah.
the sports medicine guys do arthroscopy and fix it, fix the cyst, and that takes care of the nerve.
Yeah, that's a great point. So as it ends in the infraspinatus, remember infraspinatus is your major external rotator. You only have two external rotators, the teres minor and infraspinatus, and teres minor only does about 10% of that. So it's a very important nerve for that one mechanical aspect alone. A posterior approach, folks that want to decompress it from behind, one landmark is to find your omohyoid muscle, because remember that muscle, omo means scapula, attaches onto the medial lip of that suprascapular notch. So if you're trying to dig around in this deep hole and move supraspinatus around, omohyoid is a great landmark for identifying the suprascapular nerve and staying away from the more medially located spinal accessory nerve. Posterior cord. So remember, all of our divisions up underneath the clavicle give a contribution to this posterior cord. The posterior cord terminates as our radial and axillary nerves. The branches that come off of that before, most people forget about until it's time to study for exams. But we have our subscapular nerves, upper, middle, lower. Middle subscapular, by modern definition, is called the thoracodorsal nerve. So we'll see as we move through that those nerves are extremely important, and sometimes as important as the distal branches, e.g. the axillary nerve. Posterior cord behind the axillary artery, right? That's why we call it the posterior cord, and you can see that with this retraction of the medial and lateral cords. Here we see the removed axillary artery and the medial and lateral cords. We see nicely the subscapular nerve. So you see the upper subscapular, middle subscapular, which we call thoracodorsal, and lower subscapular. Upper and lower subscapular both innervate the subscapularis, a very powerful internal rotator of the glenohumeral joint. The thoracodorsal innervates latissimus, right, an internal rotator, an adductor, and an extender of the upper limb. And then our lower subscapular, in addition, innervates the teres major. And you can, for simplicity, remember teres major is simply a small version of the latissimus dorsi. So it does the same functions, just to a less degree: internal rotation, adduction, and extension of the upper limb. These branches, upper subscapular comes from C5. From C5 and C6, we see the lower subscapular, and then counterintuitively, the middle subscapular is derived from C6, C7, and C8. So divisions, we mentioned they're deep to the clavicle. There are no branches of the divisions, so you don't have to worry about naming anything there. One of the two terminal branches of the posterior cord, axillary nerve. Axillary nerve innervates teres minor. We just mentioned was a very fairly weak external rotator of the glenohumeral joint. Its major function is to give innervation to the deltoid here, and it does so after it's passed through this little quadrangular space, or the space of Velpeau, and that's a potential compression site for the axillary nerve. Additionally, it ends on the skin of the upper lateral aspect of the arm. Radial nerve, the largest branch of the posterior cord, descends down distally and travels through our triangular interval here between the long and lateral heads of the triceps, comes down to the bottom of that triangle, and then enters into that musculospiral groove. Old name for radial nerve was musculospiral nerve, which is a better name for it, actually. It enters there, pierces the lateral intermuscular septum, and then magically, when you see it again, it's here on the anterior aspect of the arm forearm and runs anterior to the lateral epicondyle. So ulnar nerve runs posterior to the medial epicondyle, and radial nerve runs anterior to the lateral epicondyle. We see that just as it enters the cubital fossa, right, here's the radial nerve, and the radial nerve is usually from about C6, 7, and 8. Those are its primary range. That's its primary range. It can have some T1, it can have some C5, but in most people they fit that middle range. Here it splits into its deep branch and its superficial branch. The superficial branch is cutaneous and hides underneath the brachioradialis muscle all the way down to it gets to the wrist joint, and then comes out from beneath that brachioradialis and supplies the skin on the dorsum of your first and second digits. The deep branch, we're going to now change its name to posterior interosseous nerve, PIN, a favorite on neurosurgical board exams. The PIN nerve, what it does, but the first thing it does is it's going to enter between the two slips or two heads or two parts of the supinator muscle, right? And right at this proximal edge of that supinator muscle, you can have a thickening or a fibrosis, arcata froche, a favorite eponym that's thrown out at you. It enters into the supinator, and as the posterior interosseous nerve comes out into the dorsal aspect of the forearm, and we'll see that in the next slide. So at this point, our radial nerve has, before it branches, it's innervated the triceps and the anconeus muscle. It then branches, and right before that branch, it gives off a branch to the brachioradialis and to the extensor carpi radialis longus. As it branches into PIN, posterior interosseous nerve, it gives off a branch to the extensor carpi radialis brevis. It then innervates the supinator. Voila, we see it more distally, it travels out through the supinator, and now it's going to innervate the remaining extensor muscles on the forearm. Ends by innervating the dorsal wrist joint. So there's also an articular function, but no cutaneous function for this nerve. Here again, we see the superficial branch as it's hiding underneath the brachioradialis, coursing around it, coming on down more inferiorly, and then it kind of covers the skin that overlies your anatomical snuff box. I like to call the 3 Ps points of perilous passage, right? These are compression points that people pimp you on and ask you where can this nerve most likely be compressed, etc. For the radial nerve, musculospiral groove is a common point. Lateral intermuscular septum, arcata froche we just mentioned, which is that thickening of the proximal supinator muscle, and it can also be compressed by the overlying brachioradialis muscle. Medial cord. So the medial cord, we're going to look at these 4 branches. The medial brachial nerve is cutaneous to the medial arm. Medial antebrachial is cutaneous to the medial forearm. Medial pectoral nerve will innervate the pec minor and the pec major. And then finally, the more important ulnar nerve. Here we see the branches that come off high, the medial brachial. And the medial brachial carries with it intrinsically fibers that are derived from T1, part of the brachial plexus. However, if you look at a dermatome of the medial arm, you see T2 plastered there. And the reason for that is we have our second intercostal nerve gives off a branch called the intercostal brachial nerve that unites with that medial brachial nerve and brings over to the medial arm those T2 fibers. And it's those connections that allows you to have medial arm pain with cardiac ischemia on the left side. We see our medial antebrachial that crosses the elbow joint, and then you can get a glimpse of the ulnar nerve running posterior back into the cubital tunnel behind the medial epicondyle. We'll start off with the medial pectoral nerve. So medial pectoral nerve comes from the medial cord. When you look at the surface of the cadaver, it's actually reversed, so that the lateral pectoral is more medial to the medial pectoral, but their names are derived from what part of the brachial plexus they come from. And like I said, the medial pectoral gets both pectoral muscles. Lateral pectoral, as we see, just innervates the pectoralis major. Ulnar nerve, we see a glimpse of him here posteriorly in the ulnar sulcus and just about to enter between the two heads of the flexor carpi ulnaris. Often there's a thickening of this band that unites the ulnar and the humeral heads of the flexor carpi ulnaris called Osborne's ligament, which is a popular thing to ask people about on oral exams. Here, if we've sliced into the flexor carpi ulnaris and opened up Osborne's ligament, we see the ulnar nerve behind the medial epicondyle. It's already innervated the elbow joint, and now its function is to innervate the flexor carpi ulnaris, half of the flexor digitorum profundus, and all of the flexor digitorum superficialis. It runs more or less under cover of the flexor carpi ulnaris until it gets down to the wrist. And at this point, at the wrist, it's going to divide into a superficial and a deep branch. Superficial branch supplying the palmaris brevis, a clinically inconsequential muscle, and also supplying the skin of your fifth and half of your fourth digit. And then finally, the deep branch, which innervates all of your interossi muscles, your ulnar two lumbricals, and the adductor pollicis. Beautiful view of that. So Guillaume's canal has been open. We've taken the palmar carpal ligament away, right? Remember, the palmar carpal ligament covers the ulnar nerve, whereas the flexor retinaculum covers the median nerve, and those two are sometimes confused by folks. This Guillaume's canal is found here on the radial side of the pisiform bone between it and the hook of the hamate. It courses around, takes almost a right angle here, and then, as I said, innervates all of your interosseous muscles, your palmar dorsal interosseous muscles, first two the fourth and fifth lumbricals. Points of perilous passage for or compression sites for the ulnar nerve. Arcade of Struthers is simply described as a thickening of the medial intermuscular septum. Some people advocate that you have to explore up proximally for ulnar nerve compression lesions to make sure that there's not a compression site at Arcade of Struthers. Cubital tunnel as we go behind the medial epicondyle and as we dive into the flexor carpi ulnaris. Osborne's ligament that I mentioned that unites those two heads of flexor carpi ulnaris, and then Guillaume's canal. Those are the major points of potential compression. Lateral cord, musculocutaneous nerve, a simple nerve, has a sensory innervation of the lateral form in the lateral antebrachial cutaneous. It's formed by C5 and C6. The lateral pectoral nerve, which comes from this lateral cord and runs out to innervate just the pectoralis major muscle, as I showed you in an earlier slide. Here we see the musculocutaneous nerve, and up proximally, remember, it dives into the coracobrachialis muscle that you see here. So it's hiding distal to that. And the next place we would see it is if we unfolded that overlying biceps brachii, and we see it piercing coracobrachialis as it innervates it, innervating the biceps, and then innervating the brachialis muscle, which on rare occasion is also supplemented by an innervation from the radial nerve. Coracobrachialis is really the only talked about compression site for the musculocutaneous nerve. The pectoral nerve, medial pectoral nerve, lateral pectoral nerve, and they're united by this ansa pectoralis around the axillary artery. We often use medial pectoral nerve as a neurotization source for kids with Herb Duchenne palsy. So it makes an excellent nerve graft and works well because it's usually functioning in those kids. Median nerve, formed by all parts of the brachial plexus, C5 through T1, travels down, doesn't innervate anything in the arm, enters into the cubital fossa, at which point a great landmark is to find the brachial artery and the tendon of the biceps, and we use the mnemonic of TAN, right? Tendon, artery, nerve. So just medial to that brachial artery in the cubital fossa is your median nerve. The first thing it gives branches to is the pronator teres. It then enters through that pronator teres, which has two heads, and they can compress the nerve. And for median nerve compression proximal to the carpal tunnel, you have to make sure you investigate whether you have two heads compressing it. It's about at that point through the pronator teres that you give off the important branch of the median nerve in the forearm, which is your anterior interosseous nerve, which I'm going to show you. So here again, we have a superficial view. Here's our biceps tendon, our bicipital aponeurosis, and then our artery nerve. We lose sight of it until we do this. We've removed the pronator teres, and now we see this sweeping band for the flexor digitorum superficialis, and that's referred to as the sublime bridge. Sublime bridge can be a compression site for the median nerve proximal to the carpal tunnel. At about the point where the biceps tendon attaches to the radial tuberosity, our anterior interosseous nerve is given off. Remember, this innervates the wrist joint, and it gives branches to 3P muscles, right? Pronator quadratus, which is somewhat clinically inconsequential. It gives to the first two parts of the flexor digitorum profundus, and then finally is going to innervate the flexor pollicis longus that flexes the distal phalanx of your thumb. Remember, you're taught in school that if you can make an O sign and hold that sign, that your AIN's intact, and a flat O sign implies that it may not be intact. Then importantly, the median nerve will usually travel just inferior to the palmaris longus if you have a palmaris longus, absent in about 14% of us. If you have it, it protects you between that and the nerve. Right before the nerve enters into the carpal tunnel, it gives off this superficial palmar branch that supplies the palm, and that's an important delineation when you're trying to decide if you have carpal tunnel compression versus proximal compression if you have palmar sparing. We then see the recurrent branch of the median nerve here, right around the medial aspect of the thenar eminence, important branch that supplies your thenar musculature. A nice cross-section, median nerve in the carpal tunnel with all 9 tendons, right? 4 tendons from the flexor digitorum superficialis, 4 from the flexor digitorum profundus, and then the flexor pollicis longus. A compact space, not a lot of room, and you throw in an important nerve, then hence all of the carpal tunnels we release. Here's our ulnar nerve up in Guillaume's canal and superficial to the flexor retinaculum. Important point. Here we've opened the flexor retinaculum. You'll see the median nerve comes on down, innervates via this recurrent branch to the thenar muscles, and then will supply the first 2 lumbricals, and then goes up and supplies the rest of the digits cutaneously, other than your 5th and half of your 4th. Points of compression of the median nerve. You can have it compressed by the ligament of Struthers, which is totally different than the arcade of Struthers. And I'll show you a picture of the ligament. Sublime bridge that I showed you for the flexor digitorum superficialis, between the 2 heads of the pronator teres, and then obviously the carpal tunnel that we're all familiar with. Here's your so-called ligament of Struthers is a band, and it only occurs if you have this supracondylar spur. If you have one of these, as some animals do, you can have a tissue band that runs down to the medial epicondyle, and if you have it, your median nerve can run through that canal and be compressed. So arcade of Struthers can compress your ulnar nerve, ligament of Struthers can compress your median nerve. You have lots of neural connections, so when you have a patient that obviously has a lesion in a nerve and you see that there's some other clinical manifestation, it's generally because there's some crossover in these different fibers. The most commonly talked about of these are the Martin-Gruber anastomoses between the median and the ulnar nerve, usually in the proximal forearm, so something just to keep in the back of your head. Last 10 minutes, we'll do a survey of some essential anatomy of the lumbar plexus, derived by the ventral rami of T12, most people include that, down to L4, and then the continuation of that L4 helps to form your lumbosacral plexus, which we don't have enough time to talk about. Posterior abdominal wall, you see all of these branches very easily. Here's our subcostal nerve from T12, here's our 12th rib. We see our quadratus lumborum muscle, which is a good landmark for the anatomist because the iliohypogastric and ilioinguinal cross over that muscle belly. We then see the lateral femoral cutaneous. We see the femoral nerve hiding here just lateral to the psoas major, the genital femoral nerve piercing the psoas major, and then medial to the psoas major, we see the obturator nerve as it's traveling out through the obturator foramen. So subcostal nerve is T12, iliohypogastric nerve is T12 with a little mix of L1. Ilioinguinal is usually just a pure L1 nerve, so it's a good nerve to test with your cremaster reflex because it tests specifically L1 and not a mixture. Lateral femoral cutaneous out exiting just medial to the ASIS is from L2 and L3. Genital femoral from L1 and L2. Femoral L2, 3, 4. Obturator nerve L2, 3, 4. Now, lumbar plexus supplies a great bit of the skin of your lower extremity, and most our residents, for example, forget this. They remember the motor component, major motor components, but most all of the anterior thigh is from the lumbar plexus via the lateral cutaneous nerves, these anterior obturator cutaneous, and then remember the longest branch of your femoral nerve is the saphenous nerve. It leaves the femoral nerve and travels all the way down. So if we looked at a dermatome, all of those colored areas are from lumbar plexus. So it's not just something that's up in the back of the posterior abdominal wall. It doesn't do much beyond that. One clinical manifestation is if you look at where the obturator nerve supplies its cutaneous distribution, it's here, and that's an L2, 3, 4 distribution, and this Hauschip-Romberg sign where you have medial knee pain from compression of the obturator nerve, and that can usually occur from a fatty herniation through the obturator canal. You can also have disc herniation at any of those levels that gives you referred pain that's not the knee, and there are lots of people, I bet you, through the year that get their knees operated on, and it's a disc herniation that's actually a problem. Some additional parts of the cutaneous supply. For surgeons, spine surgeons, iliac crest, if you're harvesting that, lumbar plexus supplies all of that area in general. We see the lateral cutaneous branch of the iliohypogastric, then the subcostal nerves lateral branch. You see a little bit of the cluneal branches, which are not from the lumbar plexus, but they're from lumbar dorsal rami. So important not to injure those with that harvest and cause more pain. You see the cluneals here. Here's our iliohypogastric and our subcostal branches, and they basically envelop that whole iliac crest area. As we know, with the brachial plexus, it leaves the axilla from the neck with the prevertebral fascia as an axillary sheath, whereas in the lumbar plexus, we have a sheath of fascia that is on the anterior aspect of this lumbar plexus. So there's not a coating around these nerves as they go out into the thigh. Here we see our lateral femoral cutaneous, and the key word there is neuralgia paresthetica on boards. If you have compression of this nerve as it goes under or through the inguinal ligament. Here we see the genital femoral nerve with femoral branches, right, that supply the skin over the femoral triangle. And then we see these genital branches that run in through the inguinal canal and out to the anterior skin of the anterior scrotum, anterior labia majora. So compression of those genital branches can give you manifestations from a lumbar problem down into the genitalia. And then that nerve ends, the genital branch ends by supplying the lower portion of the scrotum. Important landmarks, as you see in this image, we see just in front of the hip joint, we see the femoral nerve, so anterior dislocation of the hip joint can compress the femoral nerve, and then posterior dislocation can compress, as you see here, the sciatic nerve. Obturator nerve, we see in the depths of the pelvis. It runs, remember, medial to the psoas major, out through the obturator canal, and if we see it at its termination, comes through the obturator canal, splits immediately into a posterior and anterior branch. We'll not go into the details of all the muscles that those two do. They innervate all the adductors, gracilis. Femoral nerve, as it comes underneath the inguinal ligament, supplies the quadriceps muscles, supplies the sartorius, and also supplies the pectineus muscle. Continues with its long branch, the saphenous nerve. Here we see some of the relationships on the posterior abdominal wall again. Our psoas major Here's the femoral nerve traveling between psoas major and iliacus muscle. Medial to that, we see the obturator nerve beginning to be formed. One of the last images here, we see the connections between the lumbar plexus and the sympathetic trunk. So those sympathetic trunk fibers to each of those ventral rami that are going out to the lumbar plexus are giving fibers that contain both gray ramus communicans and a white ramus communicans. So there's a preganglionic sympathetic route there. So that's in a nutshell, kind of essence of brachial lumbar plexus. If you have any questions, I can give you a good textbooks to look at, or I'll be free at lunch if you want to talk shop. Thank you for your attention.